Hi, everyone. Welcome to RheumNow's coverage of Eular 2023. We have our first of the Eular 2023 faculty daily recaps. In this session, our RheumNow faculty is going to give you their highlights of the first day, yesterday, and second day's meetings. And we'll discuss what we thought were the highlights of the meeting. You all know me, Jack Cush from Dallas. Janet, introduce yourself.
Janet Pope, London, Ontario, Canada.
And Orly.
I'm Aurélie Najm from Glasgow, UK.
Okay. So, all right. So we're all here in beautiful Milan. We're back at our rooms for bunking down for the night, recovering from 2 days of walking endlessly as you do at a convention. I've asked our faculty to come with what they thought were the highlights of the last 2 days, and we're just going to discuss a few of those. Why don't we begin with Orly?
Yeah, sure. So I'm going to start with today's highlight, and it's the PIPRA study. So it's OP0130. It was presented by Andy Cope. And for those who don't know what PIPRA stands for, is for the use of abatacept in pre-RA. And it was quite good data. So they did these randomized control trials, phase 2B, amongst above 30 centers. They included more than 200 patients, 2 groups, abatacept for 1 year versus placebo. And so as opposed to other study previously published, they were looking at patients that had because previously it was MRI synovitis. Well, this time it was really patients with seropositive, so ACPA or rheumatoid factor or both, and arthralgia, but they didn't have to have subclinical synovitis. And I think it was 73% that did have some moderate synovitis on ultrasound at baseline, but no Doppler. And so what happens is after 1 year of treatment, what you can see is that way less patients do develop RA. And when they stop the treatment after 1 year and they keep the follow-up for 2 years, what you can see as well is that, the curves tend to get together really. So it's preventive as long as people take it, but when you stop, it doesn't really reduce the long-term risk. But it was quite interesting because the symptoms were improved. And it seemed to be particularly working to prevent rheumatoid in those people that were highly seropositive for ACPA. And so this means that, there might be a subgroup that might benefit better than others, and that has to be looked at maybe more in more details. When it comes to safety, there was no new signal. I haven't seen any a number needed to treat or a number needed to harm from that study, but I think that would be something interesting to look at as well. So yeah, so it was quite good actually, and it was a bit of a different population that we have seen before. So that was good. It was quite interesting because they were less inflammatory at baseline.
So I'm going to editorialize a little, and then Janet, you're going to be the deciding vote. The thing about this study is that in the blinded part, the first year, when you're on placebo or a drug, clear separation. 29% on placebo develop RA, 6% on RA, on abatacept RA. But then in the unblinded part where they're not getting drug, they're just being followed, look, as Orly says, the lines tend to come together, but they don't come together, meaning it still is 37% versus 25% who develop RA, placebo versus whatever. All this happens in a relatively mild RA population. Acute phase reactants are kind of low, 2, 3 tender joints. It's really, I think, the ideal population that these trials should be done in. The question is this a delay? This is not prevention. This is more of a delay. And the delay that they showed was on average, a 99-day delay in those who received the drug. Now, we don't know what the long-term downstream consequences of this are. Is that really beneficial? But there are some people who don't like this data and they'll say, well, the lines come together, it didn't work. And then others will look at this data and said, but there's that 99-day delay, and the AUCs look very different here. So Janet, are these results really important and impactful, or is this disappointing?
Both. And so I can answer both of you kind of favorably, I guess. So the first thing is, I think it actually shows that in area trial, it was reproduced. Why do I say that? Because area was only the arthralgia, MRI positive, CCP positive, so ACPA positive. And where the delay, when you put all these people together, it's really the ACPA positive patients driving the data. So number one, you do delay. Number two, they felt better, even though they're starting to lose ground. Their symptoms were better controlled. Number three, what if we went another year or two? If cost wasn't an issue, safety certainly wasn't an issue in this study. And number four, I think it was a real high rate of converting to rheumatoid arthritis in this group, because often in studies, it's about 1 in 6, 15%. And here it was 25% or even 1 in 3 higher in the group that started on placebo after you went and stopped the trial. So I think that if this drug was something that was widely available at lower cost, we'd be saying, why not do it and why stop? But we're not there yet. So that's where we're a bit underwhelmed. We can't be treating RA at risk or people pre-RA at risk indefinitely, I don't think, without hard endpoints with any medication that is not that easy to get access to.
What's kind of critical to this is, what is really the rate at which a preclinical RA patient will develop RA? And the range is 20 to 60%. Kevin Dean, who lectures most on this, really says 30%. But really, that's looking at, like, the more you up the ante, the more you add in factors. ACPA alone by itself is probably low, as Janet says. It could be low as 15, probably is closer to 20, 25%. But then when you start adding in an acute phase reactant or first degree relative or higher titer or multiple autoantibodies, the rate of progression is higher. So you have an expectation based on the population. The question is, does this therapy improve the expectation or the outcomes as compared to an expectation? That's why you have to have a control population. But it's interesting to see, how people react to this data. It does have positives, does have negatives, but the question is, would you give it to your cousin who's ACPA positive and really doesn't want to get RA like her mother, who had really bad RA, and they have no swollen joints? What would you do?
Symptoms with arthralgia. I mean, you want to increase that risk factor ratio, right? So, yeah. I don't think right now, I'm agreeing that I don't think right now you really would. You'd probably say, let's watch carefully. Let's do ultrasound, because if you get Doppler, that's going to then suggest that you actually have a higher risk of erosions. But you can't be Dopplering somebody, every month, all their joints, right? It's not feasible.
So, Orly, you get the last say on this. What would you do, having looked at this data? Does it change your thinking about whether you'll treat? If you had the option of treating with abatacept, would you do it at this point?
I mean, if it was for myself or someone from my family, I think I would probably give the option. But I think there's one data that would be really relevant to have that we do not have yet, is, do the people that have been treated with abatacept and develop RA, how do they respond to the conventional synthetic DMARDs? Because, it might be that we tweak the disease in a way that is going to be milder. I mean, I don't know, it's an hypothesis, but that's a data that I would really like to see, because if you put people in remission faster, which again, it's just an hypothesis, but that might be something to add in the balance, right? But we don't have that data yet.
Yeah, and the other minor point that they made at the end, Andy Cope made at the end of the presentation, was patients who were clearly very autoinflammatory in state, having multiple rheumatoid autoantibodies, had like only 10% of them progress to RA versus being seronegative made you progress to 50%. So now the lines are much wider at the end. And that's like part of this whole abatacept story, that it seems to really be targeting for better outcomes, the seropositives. I don't know. Again, how this is going to play out, because we have multiple studies now with ABA. We have a few with methotrexate with mixed results. Hydroxychloroquine has failed. This is still not a closed book on what to do with preclinical RA. Janet, what do you want to talk about?
I want to first talk about two abstracts and not really juxtapose them, but put them together. So these are on JACC, so safety and benefit. So the first one, these are both from Thursday. So the first was an oral presentation, OP0116. And the question here was, you're looking at JACC inhibitors and comparing them to TNF inhibitors and also to other advanced therapies. And the question is there a differential benefit? And the funny thing is, yes, but. So if you look at the unadjusted raw data, TNF inhibitors looked better. They had better outcomes. But if you adjust for age, sex, disease duration, line of therapy, all the usual confounders, then that actually flips. And what that means is kind of interesting. So if you look at the adjusted analysis, the JACC inhibitor users had a better good Eular response. And interestingly, it was actually better in the older people than the TNF inhibitors. But you're going to say, well, isn't it the older people? I'm worried about safety. And that segues into the next study that I think is, it's nice because we have to figure out how to put the data together. So oral presentation OP0140, also today. So this looked at a really large RA administrative database, greater than 169,000 RA patients. And what they wanted to look at was safety signals, cardiovascular and cancer. And they were looking at the various treatment groups. So this could have lots of channeling bias. Nobody's randomized. What they're looking at is cancer on conventional synthetic DMARDs, on JACC inhibitors, TNF, and other bio-DMARDs. So they're looking at the various strata of people. And number one, cancer risk was elevated in older people, no surprise. Men more than women, no surprise. But something that might surprise us a little bit is it was also increased in those with type 2 or less likely type 1 diabetes. So if you had diabetes, you had more cancer. And I'm going to come back to that in a second. But basically, they showed that JACC inhibitors had less cancer than the conventional synthetic DMARDs, and that when you look and say, is the drug you're taking, meaning the drug class, is that a risk for getting cancer? And it wasn't. Numerically, it was a little bit higher on JACs, but the p-value was like almost 1. It was a p of 0.9 or 0.8 or something like that. So that's the first interesting thing. The other thing is, apparently there was an imbalance of some cardiovascular risk factors in the oral surveillance study. And I say apparently because I think we need to have some of these things going more to press where there's more discussion about risk. But the assumption that I have is that I've heard, but I can't verify it yet. I'm not totally positive, but that there was more diabetes in the JACC inhibitor patients than in the TNF inhibitors on oral surveillance. And this thing, this study popping up the diabetic patients having more cancer, I thought was really interesting. And in my opinion, a little bit I didn't suspect it at all. So when you put the two studies together, JACC inhibitor safety depends on what you adjust for compared to TNF inhibitors, no surprise. And that the risk factors for cancer seem to be the same risk factors in all the populations of RA patients on treatment, but that the traditional risk factors for cancer are far more likely to increase cancer and not the drug you're using. So it's a good package to kind of put together and maybe say, you know, I'm going to say it facetiously, but did the regulators get it wrong on oral surveillance? And, you know, oral surveillance is an RCT. These are different ways of looking at patient populations, cohorts, administrative database, things like that.
So there's a bevy of rebuttal abstracts ever since oral surveillance, saying, not in my hands, I don't see it. I don't know what they're talking about. And the problem with all the rebuttals is they're manufactured post hoc analyses, reworks of data. And when that was done in the past with registries and meta-analyses and large LTE follow-ups, yeah, they never found what was found in oral surveillance. The problem, the biggest problem oral surveillance has is that it was a double-blind randomized controlled trial. And Janet, doesn't that trump anything you can do with administrative claims?
Yes and no. I mean, you look at always when we're trying to say causality, we're looking at the strength of the data, and RCTs and systematic reviews are higher than certainly observational studies, registry data, where we don't even know in registry data, smoking risk. We don't know family history. We don't know if they're always taking the meds, if they have a diagnostic code, and if you have high cholesterol and you're not prescribed a drug, we might be a little bit suspicious, things like that. But I think what it probably does is makes us question that it'll be difficult to know the right answer for, but that the highest risk population was not 169,000 patients with RA on the OP0140 population. That was everybody with RA on a multitude of different drugs. So I think that the word is not fully, we're not able to fully answer it. And I think we have to just kind of look at the risk factors and say, is this something I'm willing to prescribe or not willing to prescribe in certain populations with certain diseases? And I think that's as far as I can kind of go.
Yeah, my own reflective way of thinking about this is that these different studies are like Rorschach tests for rheumatologists, that like if I don't like it because it doesn't really jive with what I do, I'm gonna look for other data, and I want something that's gonna reinforce the story I'm telling myself. And again, believe me, oral surveillance is not perfect data. We can have 9 different interpretations of oral surveillance that that tofacitinib isn't worse, it's just not as good as, and all kinds of other interpretations. But I think that I find this exercise interesting, especially when we're coming back to where we began, and so recognizing that limitation, I'll throw out a study that from yesterday that is actually in Annals of Internal Medicine. It's the study that says that low dose colchicine lessens the risk of hip and knee replacement. It's a study called the LODO-CO2 trial, the low dose colchicine 2 trial, which was devised a number of years ago and published in New England Journal in 2020, looking at patients with coronary artery disease, chronic coronary artery disease, and giving them 0.5 milligrams of colchicine a day or placebo. And it was like 2,700 patients in each group. And in the end, I think it was 1 year or 2 years, that there was like 6% cardiac events in the placebo group and 3% in the other. And it was significant. And it was a New England Journal paper. And I wasn't really aware of it. And I'm not aware that colchicine's become a mainstay of therapy in coronary artery disease patients in the cardiology world. But then again, I don't follow that. But what I find interesting is how this paper came to be. And it really, I don't know the full story, but I do know that they flashed up the results of the Canto study, which was another anti-inflammatory effort in heart failure patients that did show significant benefits on future gout risk, prevention of knee replacements, and also lung cancer, things it wasn't really designed to do, right? So they saw that, and I said, well, hey, we got this 5,400 patient long-term data set. We should see what happened to them as far as now hip and knee replacement. They know nothing about osteoarthritis incidence, arthritis meds, pain levels, HAQ scores, none of the things that you would use to predict future need for joint replacement. And they showed a 31% lowering of risk, and it was very significant. They made the result even more significant by dropping those 8% who had declared themselves as having gout. They also made it more significant to 40% lower by dropping those who needed a joint replacement within 3 months of the end of the study. So this, to my knowledge, is the first real hint that colchicine may lower the risk of anything in osteoarthritis. It's failed in hand OA, it's failed multiple times. And authors presented a slide of 12 studies with 10 of the 12 having positive results. I don't know where they got those studies from, because everything I've ever read said colchicine really, it has no effect greater than the placebo or the acetaminophen comparator. So anyway, this is my looking at a study and saying it gave us great data, but it wasn't really intended to do that. And the question is, who's going to believe this data? In running around and talking to rheumatologists, other than the ones who presented the data, most people still don't believe it.
Well, it's a problem, isn't it, with looking for the needle in the haystack, right? I can redefine my terms, I can do post hoc changes, change the population. But on the other hand, canakinumab and colchicine both can dampen IL-1. They both can work somewhat in autoinflammatory syndromes, different doses, of course. And there's a lot of overlap between what's going on in osteoarthritis, some of the changes at the level of the cellular level, and what is happening at the cellular level with some mediators, apparently, if we're looking at autoinflammatory syndromes. Otherwise, they don't look the same at all. One is not a CRP disease, and maybe that's more an erosive OA with effusions and things like that. So, I mean, it's interesting. I don't have a clue if it's the data are true, but I don't have a clue how to interpret the data to reality or when I'm going to treat patients.
Yeah.
There's one thing I'd like to mention though, because see, when I saw that, the first thing I did was to go online and look for the original paper that was published in the New England. And you know, I was thinking, did they implement that in cardiology? Again, I have no clue because I'm not a cardiologist. But there's one thing that I saw was really interesting in that paper, is that yes, it does decrease cardiovascular deaths and all the composite outcome. However, it did increase the number of deaths for non-cardiovascular related causes. And the increase of the non-cardiovascular deaths was actually almost as much as the decrease in cardiovascular deaths. So, you know, even if we think of giving this for osteoarthritis, I think we should think twice, because I think we should also look at the safety profile, and it was not great.
Yeah, I think clinical trial methodologists would have a festival with this report and what it may mean. So like Mike Putman will be all over this very soon on evidence-based rheumatology. Let's go with one more, maybe a short presentation that you want to review, Orly?
Yes, sure. So there's been a lot of discussion around the difficult to treat rheumatoid arthritis. Actually, the definition was presented last year at Eular, and then, you know, I think now we have this group of people that, yes, they do not respond to multiple therapies. But in fact, I think, you know, the one of the presentation, I think it's 0170, I think, was really interesting today, because it was looking, it's a leads group that looked into their own cohort of RA people, and there was quite a lot of them. Well, actually it's OP0134. They looked amongst these people, and in fact, you know, I think there is not one population of difficult to treat. There is different subpopulations within that, and they were describing this. So you will have those that, you know, do not respond to multiple therapy, still have high CRP, still have high synovitis, and they do have inflammatory disease. But you also have a group of people that have really high pain and not a lot of inflammation, and these people, I think you need to treat them differently than just giving them another mechanism of action. And in fact, those who were really resistant to that they call polyrefractory were in fact the 2.5%, while they have a 50% of their cohort that was corresponding to the difficult to treat definition. So I think within that definition, we need subcategories as well. And so that was quite interesting.
And you know, I fully agree. I agree. Yeah, to me, it's difficult to define, because I think there's even a third group, and I think they should all be, you know, difficult to treat group 1, 2, 3. To me, the third group might have high or low disease activity, but probably high, but they don't tolerate drugs. They cycle through, they're either non-adherent or they can't last on the right, like the prescribed dose for a period of time. And they might be difficult to treat because they've never really had a good enough chance at a proper dose to do well. And so they're all different. The way we would treat someone non-adherent or doesn't tolerate, maybe you'd add 2 low doses of something instead of high dose of one thing. For the chronic pain one, you treat the pain, not change their RA meds. And the high disease activity in RA, I think we would, who could tolerate drugs and were secondary loss of response or primary non-responders, I think we do something different, maybe give them high doses or go to even more advanced therapies in a category and look. So they're all different. I don't like the definition. It's difficult to diagnose from the definition what's really going on.
Yeah, I think that the definition's main role is going to be in future, guiding future studies, because without a definition, you can't have a logical, systematic, incisive approach to a problem that if you can't homogenize your populations in some way. So, I kind of, my lecture on difficult to treat RA is really all about pain and all about fibromyalgia and mechanical pain and whatnot, not really about a new molecule that, might be appropriate. But honestly, if someone has failed 7 biologics or targeted synthetics, would I really think an 8th one that's novel in some way is going to really be the answer? I'm actually going to bet against that. I'm not against trying it, but I have to have a good reason to use it. So, Janet, what's your last one?
Right. So really quick, because we have talked about RA and OA. So a quick OA one. So it's OP. It was yesterday, OP 0070. And it was a randomized controlled trial. This is not the first. There's been some before, but an RCT and erosive hand OA with methotrexate orally, 20 milligrams sub-Q or placebo. And I think 2 take homes are, it was a positive study, a low effect size, but positive. So not a strong effect. Number 1. Number 2, if it hasn't worked by 6 months, not going to, but it might not work earlier than that. And number 3, maybe in all those group means there might be a proportion of people in whom it is actually quite effective. So if I were going to take it to the clinic next week when I'm back from Eular, I think I would say I want someone with erosive hand OA who actually not only has a lot of tenderness and it's really bothering a person, but I'd want to see that they actually have inflammation of the joints, not bony change. It's not going to help Haverdens and Bouchards, I don't think. So I think if someone had a lot of synovitis clinically, why not try it? You could at least offer and say, this might be worth it. In 6 months, if you feel no better at all, abandon it.
Well, there's clear desperation when it comes to erosive hand OA. But there's also clear evidence that nothing works, meaning lots of biologics have been tried, mostly open label studies, and really poorly controlled, not even really well done studies. There are a few methotrexate trials in OA in general and some in hand OA that have been mostly negative. So if this falls into a meta-analysis, I don't know that it's going to ultimately win out. I'm not against trying it. Methotrexate's a safe drug, and you can have a defined period. But I like that a positive result occurred. I mean, this also bookended the other abstract in that session on denosumab, which we covered at ACR. Denosumab being used in erosive inflammatory OA, where it was shown to protect against the development of new erosions, but had no effect on pain at week 48. But what they showed in this follow-up was that there was a pain reduction at 2 years. Now, honestly, is that going to win with a regulator? Can you mechanistically understand why it would take 2 years for pain to get better? My patients are grouchy when they're not better in 3 days with whatever I give them. It doesn't matter what condition.
Right. Did they convert to more bony change where it only hurts when you're knocking your hand, but not when you're doing other things with your hands, right? The other problem with that is it's a higher dose. So we can't say, oh, because you have OP, I can treat you and we can help both your erosive hand OA possibly and help your OP because it's a higher dose than our OP dosing.
Yeah, my quickie, what it would have been, we don't have much time here, would have been the I think it was a study from Egypt of 30 patients were treated with baricitinib for lupus nephritis. And it was against an active comparator. Peter Nash has a great video on RheumNow that shows you the results. And the bottom line is it looked very good, which is surprising because baricitinib, which looked great in phase 2, did not do well in phase 3 in the BRAVE 1 and 2 studies, largely because of a high placebo response rate. But this study looked good. And the question is, do you think that study could resurrect baricitinib as a future therapy for lupus? Anyone want to go out on a limb on that?
Lilly's not going to invest further in it. Maybe when it's a not a biosimilar, a generic, who knows, right? Because after having, the failed phase 3, I don't think they touch it with a 10-foot pole. But sort of like anything, if you don't look in a large, but it would have to be, the comparison was cyclo, not MMF. It was only 30 per arm. It wasn't really, it was equivalent, but it wasn't powered to be superior or equivalent, frankly. So the power is low. But I mean, you wonder, don't you?
Yeah. Do you want to end with what you're looking forward to in the next few days? I'm looking forward to Saturday, new Eular guidelines for treatment of systemic JIA.
Yeah, I'm looking to. So tomorrow we're having a really nice debate session on digital health and smartphone apps for rheumatology with a few people, and I think it's going to be a really nice session. So I'm looking forward to that.
Excellent.
Yeah, and it looks like there might be hope for patients with Takayasu's. There's a couple of studies where it looks like there might be a superiority or 2 equal drugs, and we'll see. One's comparing 2 biologics, and another study is more retrospective and a large N though. In Takayasu's looking at azathioprine versus methotrexate, and both look like they might be okay, which is good when our patients are contemplating pregnancy, that we might have something else for them. So I think we'll see what the data really show.
Excellent. Friends, thank you so much for joining us on this discussion. Tune in, folks out there, tomorrow, same time. We're going to live stream this at 7 p.m. in Milan. That's 1 p.m. Eastern time, and you can take it from there, or you can catch the recording of it on RheumNow or on YouTube. Thanks, folks. Have a good night. Bye-bye.